Okay, good evening, everybody, and welcome to our SAPA webinar. Apologies for the delay, but we seem to be having some technical problems with Zoom, which is new to us, and we're all pretty experienced at using Zoom. Our webinar tonight is going to be a combination of a launch of our new website, as well as a discussion about COVID. And COVID has really reared its head again in terms of a third wave. We were part of a MAC Ministerial Advisory Committee meeting, Haroon and myself yesterday, chaired by Steve Alapi, and some really interesting new concepts that are coming up, some new evidence that is South African based, which is really very exciting. And so before we start with that, I'm going to just tell you a little bit more about SAPA just to tell you what we've been doing in the last little while. So just going to share that. I'm hoping that you can all see my slides. So this is our SAPA webinar. And we are going to introduce you to the SAPA team. So over the last 2 years, this has been your SAPA committee. We've had myself as the chair, then Haroon, who's got all the wisdom and the level-headedness. We've had Tanya Dennis, who has very cheerfully helped us get our website into a really brand spanking new order, together with Andrew Redfern, who's our technological guru. Zia Dangor has done everything in between and really kept our enthusiasm going. Despina Demopoulos is our secretariat, and she's also got close links to the private school sector as well. Mel Kutsia has been responsible for getting the SAPA Congress going, and we'll tell you all about that. Beira Rousseau has been our treasurer and has started the webinars, and Mati Vieja has taken over those webinars, and they've been running amazingly well. Gary Robertson has also provided much wisdom, and he's got lots of connections with SAMA as well as the College of Medicine. And then Fiona Kritzinger, who's been our pediatric management group link, as well as Nasima Khan, who moved to Australia during her tenure. And then a big thanks to Steve Binos and Daniela Lazarus, who have really helped us make our new website what it is today. And we've given it a fresh new look. And without this amazing team, we would not have been able to rejuvenate SAPA and give the new website that we are going to introduce today. So what is SAPA all about? So in March of 2019, long before the whole COVID generation, we had a meeting in Cape Town because we wanted to form an umbrella where we could share experiences and skills with the pediatric community. We wanted across a platform of general pediatrics and subspecialties, across universities and hospitals and provinces, and also across the public and private sector. And I really feel that this is what we were able to do. Very exciting that we've now, on this webinar, been able to launch our new website. And I'm going to hand over to various of our team members to actually show you what an exciting new website we have, how it can really work for you. And we're going to encourage you all to join SAPA. Despite being part of any other organization, we want you to form part of this umbrella organization of SAPA. I need to introduce our administrator, Megan James, who joined us quite recently. She has a National Diploma in Public Relations. She's a full-time mom of 2, so she knows all about children, but she's also become our SAPA administrator. She's helped with the website design and development. She's been a financial manager, chief communications officer, and that is her email address if you need to get hold of her. And this is our new pediatrics.org.za. This is our domain, and I'm going to hand over to Tanya, who's going to take over from now. Thank you very much, Tanya.
Thanks, Mignon. So this is our, so if you're looking for the SAPA website, this is it, pediatrics.org.za. We've tried to make a website that's available to all pediatricians, so the whole pediatric community really, that's really a one-stop shop that provides information, latest news about what's happening in the world in pediatrics, and just also if you're looking for a colleague, a name, a number, something that, just one place to go and find all of it. So if we go to the next slide, Mignon, when you when you see what, when you go to pediatrics.org.za, what you'll see is this. So links to our latest webinars and the historical ones, information on how to become a member, and then also a link to join or register for our conference. That section that you see at the bottom that says On the Pulse with SAPA is our latest news, which we try and update as frequently as we feel is necessary. We'll go on. There's a section that connects you with us. So we have various social media platforms, and this on the front part of the website does link to all of our social media feeds, and you're able to see everything that's going on with latest news posted there as well, and far more frequently than the website is updated. So a good place to just check in. Our upcoming events, so obviously the conference and as well as the latest webinars are available just below that. And then we've put together a lot of useful links. So that's a scrolling banner that shows a lot of things that we think that you as the pediatric community would find very helpful, just in terms of information, links to the SAJCH, the college website, all sorts of things that are useful to you. So this is this is at the top of every page. You can find a pediatrician. So that's searching for, for various people. You can contact us, you can register as a member. My profile shows about the logged in stage, which we'll go to a little bit later. But then there's lots of little tabs that you can click on with a variety of resources that are available to you. And one of the ones that was most exciting in terms of creating unity in the pediatric community, Minnie, on the next one, is our links with all of our subspecialties. So this is the, if you click on the Societies tab, we've invited all of the subspecialty organizations to create just a little blurb on the website. So if you're looking for any of the subspecialties, they hopefully would have a little bit of a link on the page, and that takes you directly into with information about their websites and how to contact them as well. And the next one. So the final slide of this section is just showing you which organizations have already chosen to join in that, in this one. And we're obviously hoping to have all of the pediatric subspecialties represented within the next couple of weeks and months. They're all invited and happy obviously to have all of them available. And so now to Prof Saluji for the first part of the COVID webinar.
That's not me. Hi, everybody. We've got an unforeseen problem in that Professor Madhi, one of our panelists, unfortunately has not been able to get in. So at this stage, we'll continue to try and get Shabir in, but I'm afraid that Shabir is not available at the moment. We've been trying for the last 15 minutes. Anyway, we will continue, and it gives me great pleasure then to certainly ask the other panelists, Professor Heather Zar, who I think most of us would know. Heather's professor at the Lung Institute at UCT. She's the former head of department at UCT. So we'll start the conversation, and hopefully during this we'll try and get Professor Madhi in. So Heather, if you can perhaps just put on your video and we can perhaps start. Sorry, Heather, it's going to be a conversation between you and I. And hopefully Shabir will be able to join us. This problem with having to register with Zoom was unanticipated.
Yeah.
So we've got three components to this, and we're going to break them up. We're starting with the whole issue of transmission of COVID, and specifically the role of children. So Heather, I was going to ask a question to both you and Shabir. In fact, 10 questions. I want to do them very, very quickly. So you'll get a chance to answer each of these questions, and then perhaps we can have a brief discussion about it. So for my first question is, are children less susceptible to coronavirus infection than adults? And basically, I was looking for a yes, no, or we really don't know. It's not you don't know, the evidence is not there. But are children less susceptible to coronavirus infection than adults?
I think the evidence is yes.
Okay. Are children
do you
more
want to
prone?
expand? Do you want me to expand?
I'll ask you to expand perhaps once we've gone through these 10 quick questions. Are children more prone to asymptomatic or subclinical infection than adults?
Yes.
Okay. Are most children with COVID infection asymptomatic?
Definitely yes.
Okay. Can asymptomatic children transmit the virus?
Yes.
Okay. Now, do children transmit as much as adults?
No.
Okay. So question 6, are younger children less likely than adults to introduce the virus into a household?
Younger children are less likely to introduce the virus, yes.
How about older adolescents, say 16-year-olds or 18-year-olds? Are they less likely than adults to introduce the virus into homes?
So I think there the risk is approaching that of adults.
Okay. Question 8, is the new beta variant affecting children disproportionately compared to the previous virus? So what I'm really asking is that, is there a higher proportion of infections of children compared to adults now that we've got this new variant?
There are more infections, but it's not a higher proportion in children.
Okay. And has it affected admission patterns in any way? Are more children being admitted with the beta variant?
So I think this is also different in children and adults, where the adult literature shows an increased severity and more admissions. This is not the case in children. I think the admission rate has been very constant if you compare our first and second waves.
All right. And perhaps then the last question, which is school-based transmission of the virus an important component of community virus spread?
I think other areas of community transmission are much more important. I think there's relatively...
Thanks, Heather. As I said, that was just an idea to give the members of this webinar some idea of perhaps what the answers may be. But I'm happy for us to have a brief conversation about any of these points. Perhaps let me ask you, Heather, that the question was, has the science changed related to transmission of the virus? And are you saying anything differently from what you were saying last year? How much has the science changed? What have we learned? Has your mind changed about anything? Or is the science still very much what we were saying last year?
No, thank you, Haroon. And I'm sorry Shabir isn't on to help me with all these difficult questions. But good evening, everyone, and colleagues everywhere. And I'm sure other people will also be able to contribute. So I think the science has moved hugely. You remember in the beginning of the pandemic, we were talking about contact transmission as the major form of transmission. We weren't even wearing masks. When we started to say wear masks and aerosol transmission, there was huge pushback. Well, we now understand that aerosol transmission is a major, probably the major form of transmission. I think that's the one thing that's changed. The other thing is we've seen variants emerge, right? So the South African variant, which is correctly now called the beta variant, we know is much more transmissible. It's the same for the Delta variant, which is the variant in India. We know this is much more transmissible than the original virus. And this increased transmissibility has occurred because of mutations in the virus, some of which are in the receptor binding domain, which binds to the viral receptor, which is the ACE2 receptor. So I think we are faced with new data on transmissibility showing that it's airborne. We also know that the variants are more transmissible. And so I think the science has moved a lot in that way. And then there's a lot of work around, well, if you've seen original virus, either with natural infection or you immunized again with a vaccine that was primarily developed against spike protein of original virus, will that protect you against variants? And will vaccines protect against infection and transmission? And I think the science of that has also evolved hugely. I mean, I think what I want to say now in our third wave is that this third wave that is currently being experienced in different provinces, I think many people know it arose in the Northern Cape, it spread to the Free State, it's now in Gauteng in a huge way. It's still driven by the beta variant. It's not because of an introduction of a new variant, such as the Delta variant. So the first wave in our country was driven by the original virus. The second wave was predominantly beta variant, the South African variant, and the current wave now is also predominantly beta variant. And so you may ask, well, why is this happening, right, suddenly? And what we know is if you look at, for example, the UK Mobility Index, which tells you how many people are visiting shopping centres, how much social activity is happening, how much mobility is happening in communities. As the mobility index goes up, so transmission increases. And we've seen this in South Africa. The mobility index has increased, coupled with lack of non-pharmacological interventions, so people not wearing masks, people not keeping social distance, indoor gatherings particularly. We know transmission is much more indoors related to airborne transmission, and lack of immunization. And maybe with winter coming, more indoor activity. And so this is a confluence of social behavioral factors coming together in the context of a very transmissible variant. And I think this is what we're seeing now in the third wave. And the issue of whether prior infections has protected, I think it's really interesting that the provinces that are seeing the biggest spikes in cases, or where the third wave is really happening, the Northern Cape, the Free State, had relatively low numbers during the second wave. And a province like KwaZulu-Natal, where there were huge numbers in the second wave, is actually seeing, well, so far, relatively few cases in the third wave. And I think there is emerging evidence, and some of it is quite strong, that prior infection, and Shabir may disagree with me here, but I'll quote my evidence, and when he gets on, he can quote his, but that prior infection, natural infection with original virus is protective, somewhat protective against beta variant, and certainly if you've had severe disease or have high antibody titers. You want me to go on with the evidence?
That's fine, Heather. So I want to invite anybody who wants to ask questions to put the questions on the chat line. Professor Ziad Dengo will be monitoring the questions, and he will then raise the issues because he'll keep an eye on the questions. So Ziad, I don't know if there's any questions already that have come through that you want to raise. Okay, so Ziad, do you want to just unmute yourself? Are there any questions you want to raise? Okay, so maybe Mignon, perhaps you can monitor the chat line.
I'm just looking at the chat. I'm also looking, so I would really want to ask people to pop their questions in. I had a question this afternoon. I just want to quickly get it from somebody asking about whether if children have symptoms in the public sector, should you be testing them or just isolate them for 10 to 14 days? It seems in the private sector, people are testing their kids for 800 Rand a time, and this negatively impacts schooling. So what's the feeling on that?
So I think it also depends on the age of the child. Certainly if it's an adolescent, I would test. And you can do rapid testing, right? I think we're underutilizing rapid testing in children. There's been some debate as to how sensitive. It's highly specific. So if you have a positive rapid test, that's very useful. If it's negative, you should follow with a PCR. But rapid tests are much cheaper, and they give you an answer very quickly. Obviously, they're associated with viral load, and that's why they're not as sensitive. But actually, Gary sent me a paper a short while ago showing actually remarkably high sensitivity for rapid testing in children, approaching like 90%. So I think the importance of identifying children who are infected is for isolation, for household isolation, and obviously, to prevent further transmission.
Okay, then there's another question. What do we do about children presenting with nasal congestion? The Delta variant seems to present with nasal congestion, especially in the younger, and I'm going to add to that, especially in the winter months.
Yeah. So I think this is an important question. And yes, we're hearing that upper respiratory symptoms, particularly nasal congestion, sinusitis, these kind of symptoms seem from clinicians to go with the Delta variant more. I think, we can't be testing every child who's got a blocked nose or a nasal congestion. And we're in the winter season where, in fact, RSV is around and we've seen influenza around. So, you know, I think again, we have to keep some sort of perspective on this. We can't be testing all children, but we should be adopting these non-pharmacological interventions anyway, because as Haroon asked me, 85% of, maybe that's too high, but by far the majority of children who are infected are asymptomatic. So you actually have to keep a distance from anyone. And I just want to mention a study, an amazing study that Cheryl Cohen and the NICD have done. It's called the FIRST study, and it's a household study done over a year in 2 locations, an urban area, Klerksdorp, and a rural area in Agincourt. And so they swabbed all the household members and they followed with serology for COVID. And what did they find? They found that over this period, so that's over the first 2 waves, around a third of people, in fact, were infected. And infection was defined as either seroconversion or a positive PCR. And 65% of people were asymptomatic. So the message here is the majority of people, children and adults, are asymptomatic. You have to wear your mask. You have to keep social distance. You don't know who has COVID.
Great. That's then I'm just going to add another one. The schooling, we're going to cohort because there's a specific section on schooling, but is rapid testing reliable in asymptomatic kids? We've been seeing the rapid is negative on them, but the PCR is positive. And I know that's feeling in our hospital as well.
I think that's a good observation. It's related to viral load, right? So the higher your viral load, the more likely you will have a rapid positive. Generally, higher viral loads go with more severe illness. So absolutely correct. You know, in non-symptomatic children, I don't think it's worth doing a rapid. In symptomatic children who are being hospitalized, it's a good, it can serve as an initial good test, because if you get a positive, it's quick and easy to, well, not easy, but quick to cohort. But if you have a negative, you must definitely follow it with PCR, which is much more sensitive.
So then adding on to that, should a child with a runny nose and no other symptoms go to school?
Okay, so we're getting into the school issue. And maybe I must answer Haroon's questions before about the role of children in transmission and the role of children in infection. And I want to go back to Cheryl's first study, where obviously, you know, a fair proportion of household participants were children. And so that data, and it's not yet published, and I really thank Cheryl for allowing me to say a few words about it. She has presented it in public fora. Shows that children are much less likely to get infected than adults, particularly children under 12 years of age. And if you look at who introduces the virus into the household, so who's the index case, children and adolescents are much, much less likely to be the index case. In other words, the index case is coming in from an adult who's acquired the virus in the community, which means that children are not a major reservoir of transmission in households. And the same is probably true for schools. And I think that's been borne out by our own data, that if you look at the 2 waves and now the 3rd wave, and you look at the relationship to school opening and closing, there's absolutely no relationship, not to infections and not to hospitalizations in children. That's the first thing. And the second thing is, if you look at global data, like the UK data on infections in children, very few, and others, there's US data, there's data, there's accumulating and quite a lot of global data. Almost uniformly, this data shows low risk of transmission in schools, very low risk of transmission from a child to, for example, a staff member. But introduction in schools, often by an adult member. And then there are outbreaks reported in adolescent clusters. And I think adolescents are, as a group, are probably the group to focus on in terms of mask wearing, social distancing, the kinds of non-pharmacological interventions that we really need, because we're seeing, for example, in the third wave, many more infections in adolescents, not severe infections. The rate of hospitalization hasn't changed, but we are seeing many more infections. And I think we all know adolescent behavior. I hope my daughter's not listening to me. But right, adolescents go out, they party, they don't wear their masks. You can go down, certainly in Cape Town, if you go around to some of the restaurants or bars, and full of adolescents, hugging, kissing, other stuff. No social distance, and it's ripe for transmission.
Okay, Heather, well, thank you very much. I think at this stage we'll stop the transmission discussion. We're going to move on to the school discussion. But Heather, just to give you a break, and at this stage I'll ask Mignon to perhaps just give us a short commercial from the SAPA point of view. So we're taking a commercial break, ladies and gentlemen, just to give Heather a small break.
Right. So moving on from here, I'm going to let Andrew Redfern tell us why you need to become a SAPA member.
Hi, everyone. I hope you can hear me okay. Thanks, Mignon. So in recent years, it actually hasn't been possible to become a SAPA member. So we really are delighted to be able to invite people to become members again. Becoming a member is a simple process on the website, the pediatrics.org.za website, and it will require you to create a user profile on the website, which will then give you added functionality, which I'm going to chat about in a bit. The Constitution of SAPA does say that only specialist pediatricians can be full members, but there was a question in the chat, and for those on YouTube as well, we have created additional membership categories, so for registrars and then for other people interested in child health or interested in joining SAPA. So you won't be full members, but you can definitely join the community, and we want to be inclusive and representative of the broader pediatric and child health community. It's only 500 Rand a year if you're a specialist pediatrician and 300 Rand for the other categories. And what do you get for that money? Well, as Mignon alluded to, we really want SAPA to become the unifying body in South Africa for the child health community. And that desire for unity and community, and particularly connecting the disconnected, was a powerful motivator for us to choose this website platform that we've gone for. And so when you become a member and are able to log into the website, you'll see this sort of screen that is being shown, where you are able to, for example, share resources with other members. So currently, I get shared lots of stuff via a WhatsApp group around school and vaccine and teachers and that sort of thing, and articles. But now we can share it with the broader SAPA community. Next slide, Mignon. You can also connect with other people that are interested in what you're interested in. Next slide, Mignon. So there are groups. So whether you are joining a registrar group, whether you want to join a special interest group, for example, COVID in schools, whether you want to find other people in your province or in your subspeciality, you can connect with people in these groups. So this is that umbrella sort of concept that we were talking about, and connect with people that way. And then the feed in the logged in state enables you to interact in a similar way to other social media platforms, but without the ads. Next slide, Mignon, and you can skip this one as well. So the best way to stay up to date with SAPA is to follow us on our Facebook or our Twitter pages. But if you do become a member, you also get a weekly digest email to your inbox with upcoming events. And then lastly, just want to invite everyone to get involved, whether you want to join with some others in terms of an advocacy statement or developing educational resources, whether you want to be a social media influencer. For us, we really want to make a difference and be a voice for children. And so we invite everyone to get involved. So become a member, but also express your interest to get involved. We can use all the hands you've got. And the best way to do that would be to email info@pediatrics.org.za, and then we'll put you in touch with the right people. I'll hand over to Despina.
Thank you. So what's amazing on this website is that we've also put a section regarding resources. So if you actually go into the tab on the right, on the top right, you'll actually see a section for resources, and then there's clinicians and parents. So what we've tried to do is update our resources regularly. Obviously, this is something that's growing. And currently, we have a few resources for parents specifically. You can see from the American Academy, Up to Date, Colic, and we've actually got a couple of things that we've put up to date you could use as a pediatrician to share with your patients and their parents. Next slide, please. But for the clinicians, for us, what we're really aiming to is to update and have a one place that you can go to find all the latest resources. So currently on the website, there are different categories: allergy, endocrinology, critical care, essential medicine. And if you have a look at the critical care section, obviously my favorite section, you'd see there we've uploaded the guidelines for determination of brain death in infants and children, the latest that's out there. So these resources are very useful. You can just go and click on the tab and you can find the latest in one place. Thank you.
Thank you very much to Andrea and to Despina. And we now move on to the very controversial area of schooling and the third wave. And I know a lot of the questions in the chat group came up with that. I just want to really thank Professor Shabir Madhi for his extreme patience in trying to get into this website. It's lovely to have you. And Haroon, back over to you.
Thank you.
You just stop sharing. Great. Thanks very much.
All right. So the really good news is that Professor Madhi has finally been able to get through the Zoom barrier, and he's joined us. So Heather, again, thank you very much for holding out for the first session. It was fantastic. We now get on to the more controversial and more difficult issue of schooling and schooling in the third wave. So Shabir, I think just to introduce Professor Madhi, I think most of us again would know him, but Professor Madhi is the Professor of Vaccinology at Wits University, and since January he's also now the Dean of the Health Science Faculty at Wits. So welcome, Shabir. I see your picture. I don't see you moving as well. Please put on your video. Fantastic. I can see you now. All right, so I'm going to cover 4 issues in this segment about school health. We're going to look at the question of should all schools be closing again? We're going to be looking at the question of can we move from the current system of rotation where children either come one day and don't come the next day, or come one week and the other, to a system where all children can get into school. We'll look briefly at the science of the PPE again, and finally we'll talk about school sports. So those are the 4 main issues. But just to introduce the issue, I think people know that SAPA, since last year, has been at the forefront of the argument that children should be attending schools. And as one wave and the next wave has come and gone, we've persisted in this in the argument that children should be attending schools. We've had opposition, surprisingly not from the education department. The education department we've been trying to support, and they've been very keen to keep children at school, but certainly we've had debates in the media with the teacher unions and also some school parents' bodies. But I think on the whole, there's a kind of sense that our view was vindicated. But we're now in the third wave, and in certain provinces like Gauteng, it's predicted to be even worse. So the pressure is on again. We're in the middle of a third wave. Should schools be closing? So Shabir, that's the first question for you. And Heather, I'm going to ask you the same questions. Should all schools close now that the third wave is upon us? Shabir?
So thanks, Arun, and my apologies for this difficulty on getting on. And I'm glad that you left the more controversial questions for me. Highly appreciated. So should schools be closed? So I think what we need to do is, firstly, we need to reflect as to what if we learned during the course of the first 2 waves in relation to infection in children, as well as whether the opening of schools during the course of the first as well as the second wave was temporarily associated with an increase in transmission in the community. Now, what we've learned with a serious survey that was done in Gauteng at a household level, and that was completed at a time when the second wave was peaking, is that despite all of the school closures that took place in 2020, the infection rate in children under the age of 19 was no different compared with the infection rate in adults. in children under the age of 19 in Gauteng, across all of the different districts, the infection rate was roughly about 18%, and in adults it was 19%. So despite all of the school closures that occurred during the course of 2020, absolutely no impact in relation to whether children got infected or not any differently from the general population. The next thing is that NICD did an analysis which carefully looked at the opening and closing of schools in relation as to whether there was any uptick in viral activity that was temporarily related to the opening of schools. And the short answer is, again, no difference. Now, obviously, all of the concern around children being vectors of transmission of the virus was stemmed from influenza. And we know that when it comes to influenza, children are an important vector. But the reason for that is simply because children are relatively naive to influenza virus. So because they're relatively naive, they're more likely to get infected if exposed with influenza virus. They're more likely to become more infectious if exposed to influenza virus compared to adults. So children do become vectors of transmission for respiratory pathogens, and not just influenza, also pneumococcus as an example, something completely different. But children are the most important vectors of transmission of influenza virus, of pneumococcus, but that's because they're relatively naive. Now, when you come to SARS-CoV-2, you're dealing not with children only being relatively naive or being naive to the virus, you're dealing with the entire population being naive to the virus. So bottom line is that children do spread the virus without any question, and especially children in the 12 to 19-month age group. But again, all of the evidence shows that children are most likely to spread the virus not to adults, but rather to those individuals that they're more likely to be in social contact with. So teenagers are more likely to infect other teenagers, adults are more likely to infect adults. And even at the household level, what's been shown, and again, another really good work from Cheryl Cohen at NICD, which basically shows that looking at household transmissions studies in terms of who is responsible for bringing the virus into the household, it is rarely ever children under the age of 12 that are responsible for bringing the virus into the household. They will get infected in the household, but they're not the ones that are bringing the virus in the household. Now, we would have been having a very different discussion if there was any possibility of this virus being eliminated, of the virus disappearing anytime soon, or if we were at a very early stage of the outbreak where we were able to contain the spread of the virus. That's not where we are in South Africa. This virus has heated tremendously, and all indications are that even with vaccines, unfortunately, we're probably going to have a fourth wave, and if not a fifth wave. And we would continue having these resurgences for the foreseeable future, unfortunately, into 2020 very easily. Can we continue punishing children for something that they're not responsible for something that they rarely ever develop severe disease? That's something that's not a threat to them, but at the same time, essentially deprive them of education, deprive them of feeding schemes, deprive them of being children. The short answer is I don't believe we can do that. So irrespective of where we are in epidemic, and the current wave as an example in Gauteng, which we're probably almost peaking at, there's very little to be gained from keeping children out of schools.
Okay, Shabir, so thank you very much for that. So your answer is that even though we're in a situation of high spread right now, you believe schools should stay open, and I fully agree with that view. Heather, do you have an alternate view on this issue?
Yeah, no, I also strongly agree with that. I think it's imperative that we keep schools open. We've seen the indirect effects on COVID on children, mental health, nutrition schemes, educational fallout, etc., etc. And I think actually, and this is a point that Mary Metcalf pointed out to me that I hadn't thought about, but actually schools provide a structured environment in which the virus can be contained. If we close schools, particularly in poor socioeconomic areas, where do children and adolescents go? They go to crowded conditions. The risk of transmission in communities in that setting is actually even higher. So you know, as Mary said, schools are actually a mitigating factor that may in fact help to prevent transmission. I think it's imperative that we keep schools open. Of course, one size doesn't fit all, and there may be a different strategy, for example, and for a province, you know, like Gauteng at this moment compared to KwaZulu-Natal or on the Western Cape. I mean, I think the issue is also around potential threat to staff, and I think it is absolutely great that school staff are now being vaccinated, and I think that's not only about threat to staff, but it's about staff being the source of infection in schools and potentially infecting in others. So you know, I think with vaccinating staff, we also will better be able to protect those staff, certainly against severe infection. And there's probably, you know, less of a worry around transmission. But I also do want to say that, you know, I think we have to open schools and keep them open in a very responsible way. So the non-pharmacological interventions are still essential: mask wearing, social distance, open the windows in school classrooms. Transmission is much more indoors than outdoors. But for child health, I think it's actually imperative that we keep schools open. We've lost so much time in education in this country over the last year.
So thanks for that. So the follow-up question is that, recognizing that the older adolescents are at higher risk of transmission and of getting ill, should we be treating them differently? Do we keep schools open, both primary and high schools, or should we be treating them differently? Shabir?
Yeah, I mean, as the body, as Heather pointed out, and as I alluded to earlier, keeping children out of school doesn't mean they're any less likely to get infected. Children that are not in schools, in the low-income settings, they're all on the streets. They're playing together without the mask, and that's what I saw literally when I used to drive to Beira each day during level 5 lockdown. Forget level 2 and 3 lockdown. So we need to decide. We need to first establish whether there's going to be any difference in risk of a child being infected in school than keeping when they're outside of schools, and especially, as Heather correctly pointed out, school is a much more controlled environment than allowing children to be outside or gathering in each other's homes, which is more likely what is happening indoors in a poorly ventilated area. And the way to mitigate that, the two most important, I think we also need to start rationalizing on what non-pharmacological interventions really are impactful. And the two most impactful non-pharmacological interventions, firstly, is ensuring good ventilation if indoors. That probably is the most important non-pharmacological intervention. We know that 80% of infections are because of directly or indirectly a consequence of gatherings that occur indoors. And the second most important one is the wearing of face masks. Those are the two most important. And if you adopt those two strategies in schools, you're going to minimize the chances of there being an outbreak. Unfortunately, there are going to be some outbreaks, but those outbreaks are taking place at a household level right now. Those outbreaks are taking place amongst children that are playing on the streets. So it's not going to be anything new. The only one other thing I need to caution about is, I think it's great news that teachers are being vaccinated, but I don't think it's going to do much in terms of protecting the majority of teachers from becoming sick with COVID. It's going to protect them against severe disease. But the J&J vaccine in particular, as an example, is going to have a very nominal impact when it comes to protecting against being infectious or being infected with the beta variant, and also against developing mild COVID-19. So we need to be careful how we message this. So for me, it's great teachers are being vaccinated, because it sort of removes an excuse for them wanting not to be in school. And I think it takes care of that. It's going to protect them from developing severe disease, which is what our goal is when it comes to COVID-19 vaccine programs in South Africa. Our goal is not to prevent people from getting infected. Unfortunately, the current tools that we've got, and especially with the vaccines such as J&J and most other vaccines, these vaccines are not going to protect you from being infected. It's not going to prevent you from developing mild COVID-19, or it will have a very modest effectiveness against mild disease.
Okay, Shabir. So we'll get on to vaccines as a last point. Let me take two more issues that are very pertinent now. People may be aware that in the Government Gazette last month, after the school holidays from the 26th of July all children in primary schools will be returning. The rotational system has been shown to be having devastating effects on learning. It just hasn't helped children that they come in one day, they're not there the next day. So all primary school children are from the 26th July are going to be going. The reason, the problem with that, of course, is that that whole physical distancing issue comes to the fore. We've argued that 1 meter is what they needed. Certainly, if most classrooms have 40 children, once that happens, the classrooms at 1 meter is going to go. I'm certainly aware of a study from Massachusetts that compared 1.5 to 1 meter in the setting where children had masks and the other protective, and they found that there was no difference. The problem now is we're going to be getting into maybe 0.5 meter or 3/4 meter. But that's where we're going, and that's just for primary schools, not high schools. How uncomfortable or comfortable are you with that situation, Heather? Do you think that we can tolerate that? And it's all about risk against benefit. It's not we know that this whole debate is about risk and benefit, but should we tolerate that? That's what the education department wants to do. Do you think from a health perspective, this is dangerous, or is it something we should be accepting?
So I saw there was a question about, is 1 meter okay over 1.5 meters? I think the CDC a number of months ago went to 3 feet, which is just under 1 meter in the context of masks. And as people know now, the CDC has actually removed masks because there's a high uptake of vaccination in the States. But the bottom line is 1 meter should be fine, as good as 1.5 meters. I think Shabir's point about ventilation is key. For me, what is, and to sort of marry this with my point about aerosol transmission. If you're wearing a mask and you're outside, it's okay. If you're wearing a mask and the windows are open, it's okay. So I think we should tolerate closer distances for the greater benefit. I also think if you look at children's behavior, particularly young children, right? They toss, they tumble, they're very close to each other all the time. And yet, we haven't seen them a major spread in schools. There was also a question about what age of children should wear masks, and I don't know whether you want to get into that now, but certainly in children, WHO doesn't recommend masks for children under 5 or 6, and the CDC previously didn't recommend masks for children under 2. But, and I think it's, again, not one size fits all. Children, if they're outside, can take off their masks. They can take mask breaks if there's distance. Probably if they're in a very well ventilated classroom and there's distance, it's also okay to take off masks. We all know how difficult it is to wear masks continuously. But to come directly to your point, I think, yes, we need to tolerate closer distances, bearing in mind ventilation and mask wearing.
Okay, so Shabir, you can come in on this, but I've got one more question before we take a break. And that question's parents have been quite upset about, is the whole issue of contact sports. Again, the education department has banned that, for lack of a better word. Non-contact sports allowed, but contact sports are not allowed. Certainly when I looked for the evidence of this, there's not a lot of evidence. We know the story about the choirs transmitting. I found some evidence of wrestling indoors and maybe even ice hockey. Not a lot of evidence. Is there any reason to believe that children shouldn't be allowed to play contact sports, rugby, soccer, particularly if they're playing it outside?
If they're playing outside, they should be playing everything. It makes absolutely no sense to ban contact sports. Again, just to reiterate, evidence is overwhelming that this is mainly airborne transmission. A person really needs to be sick and coughing and sputtering to infect another person directly, and that person wouldn't be playing contact sport to start off with if they're so ill. So banning contact sports is as good and as effective as banning people from walking on a beach, which is not effective and has zero value.
Okay, so you're very clear about that, Shabir. Miriam, I'm going. Time's moving on, but if there are any, sorry, Heather, do you want to come in?
No, I agree, but I just wanted to make a comment, Haroon, on your observation about the transmission through choirs. We also know that shouting and very loud vocalizing is a form of transmission. Will promote transmission, and I think in the case of the choirs that are reported, they're indoor activities, and there's a lot of vocalization, and it's adults. So again, great evidence for the transmission pattern being aerosol. I agree with Shabira. Shabira, I'm agreeing with you a lot tonight.
Mina, we probably have time for one or two questions. We need to move on to the next segment, but is there anything that you've seen in the chat that you want to ask either Shabira or Heather?
I think the questions are all being answered as we go along. There are some questions about vaccinations, and I know that that's the next section. So I think we should probably move on. I must say, from the MAC group discussion we had yesterday, the issue that really stuck in my mind is that the teachers were saying, as soon as the kids leave the classrooms and go out the gate, they all drop their masks. So I think there's a lot to be said for schools being a more controlled environment where everybody's wearing masks with good ventilation. And so not to impair not just the education, but the safety of girl learners, particularly, and school nutrition. I think for me, that is something that's really real about getting kids all back to school. So that was my take on it.
All right. So we're going to give both Shabir and Heather a short break. It's time for another commercial. This is brought to you from SAPA.
You're making a good radio presenter, Haroon. I'm going to hand over to Mati Viecha, who has some information for us. Thank you, Mati.
Hi, everyone. So I would just want to alert you that the South African Journal of Child Health is now the SAPA's official journal. SAPA would really like to encourage the pediatric community to publish their research in this journal, to read this journal, and really welcomes pediatricians with an interest in research to become reviewers for our journal. Further details about this, newsletters, links to the journal can be found on our beautiful new website. And then for our webinars, next slide, Mignon. So we are so excited and grateful for everyone that's joined our webinars over the last 2 years. Actually, it's been going. It is every month, the last Wednesday at 5 p.m. and it's normally up to 90 minutes. Our webinars has really grown over the last year, and we really aim to get good local speakers from all pediatric disciplines across South Africa to give us great quality, evidence-based updates, guidelines, and expert opinions on common and topical pediatric conditions. From August, we will be CPD accredited as well. So most of you can find most of our webinars are recorded, and these recordings can be found on our YouTube channel. And this month, we are lucky enough to have 2 webinars because today is a special edition. So you guys can join us same place, same time next week. If you want to get reminders and if you want to be able to get notifications, please go and have a look at our website and sign yourself up for future webinars. Thank you so much.
Thank you, Marty, and thank you for all the incredible work you do in putting this all together. I just want to advertise that tonight we've actually got almost 500 people between the Zoom and the YouTube. So that's really amazing. So thank you to everybody for that. Right, Mel, do you want to take over with the exciting Congress news?
Thanks, Mignon. So we hope that everyone that's actually attending this webinar tonight will be joining us for SAPA's first virtual Congress. As you can see, it's from the 13th to the 15th of August this year. The program is really very diverse, it's relevant, and it's really exciting. And you can find the program on the Congress website, which is sapa2021.co.za. All healthcare professionals are invited to join the Congress, and our theme for this year, in keeping with SAPA's new identity, is also striving for thriving kids. Next slide, please, Mignon. So this year, one of the focus points for the Congress is the physical and mental well-being of all the healthcare professionals. So we've arranged a pre-Congress 5K virtual run or walk, whatever you're comfortable with. And all the funds raised will be donated to our Congress charity partner this year, which is Reach for a Dream. And once you've done your run or your walk, we'd really like you to share your photos and your results with us. So let's all get active together. We have also arranged for a yoga session this year and a mindfulness session to kick off the Saturday and the Sunday's activities of the program. And in the first plenary session of the program, we'll actually also be discussing caring for the caregiver, which is very important. Next slide, please, Mignon. So the Congress starts on the Friday with 12 virtual workshops, which will be offered in various tracks, so you can attend more than one workshop. And the workshops will be as practical as possible, keeping in mind that this is a virtual platform because of COVID-19. We'll be covering topics like cerebral functioning monitoring, ECG interpretation, point of care ultrasound, tracheostomy essentials, palliative care planning, skin prick testing, and quite a few more. So the workshops are going to be really very exciting, and I'd advise that you register for those. Next slide, please, Mignon. The program for the Saturday and the Sunday is also very exciting and includes plenary sessions like the role of social media in medicine and the aftermath of COVID-19, to just name two. During the Saturday and the Sunday, there'll be 4 parallel sessions running, which will cover a diversity of topics and subspecialities. We also have a slot for the oral abstracts, which will be presented on both days, and they'll be presented in what we've called the blockbuster sessions. There'll also be an e-poster cafe running throughout the conference where all the poster abstracts can be viewed. And we really hope that you'll be able to meet some of the experts in some of our allocated coffee breaks. Next slide, please. So this Congress will be CPD accredited, and we really do want to encourage everybody to register at sapa2021.co.za. Thank you very much.
Thank you very much, Mel. To you and your team of Janeel Joshi, Anne Buchner, and under the wise eyes of Robin Green, I think University of Pretoria has really outdone themselves. You've organized a real in-person Congress and then had to switch to a virtual Congress. So really well done to your team, and we really look forward to a very exciting Congress. So we now move back to the last part of our discussion, to children and vaccination. And Haroon, I've just got 2 questions that's come up on our executive group saying, I'm just concerned about transmission through fomite, as kids are always picking their noses and they like sharing everything, including lollipops, because sharing is caring. So that's one good question. And then the other question was just about boarding schools, but I'm going to stop sharing and I'm going to move over to the esteemed panel again. Thank you, guys.
Okay, so we'll maybe either Shabir or Heather will take those 2 questions if they want to. We're moving on to the last and final segment of the webinar, and this is about vaccines and children. Just 2 days ago, the WHO published the revised advice about who should be getting vaccines. And the WHO is very clear that it says children should not be vaccinated for the moment. And they also made the point that they say that there's not enough evidence yet on the use of vaccines against COVID for children to make clear recommendations. This is different from the US FDA, who already in May made the recommendation that children over the age of 12 should be vaccinated. And obviously that raises some ethical issues in terms of vaccine availability, but we won't be going there today. So where I want to go with this discussion, firstly, Shabir, maybe this question to you, just give us a quick sense of the state of vaccine availability for children, and what do we know about its safety and efficacy in children? And then we'll go on to the bigger question of what do we do in South Africa, but perhaps just lay down the situation. And perhaps make some comment on the recent work that suggests that at least 7 adolescents had symptomatic myocarditis. How concerning is that?
Thanks, Arun. So the only vaccine for which there's efficacy data right now in children is for the Pfizer-BioNTech vaccine. And it's got close on to 100% efficacy in children. And that, I think, was in the 12 to 16-year age group, which is great news. But at the same time, as you correctly point out, there's 2 big issues. So first question we need to ask is, why are we vaccinating children? Are we trying to protect them against severe disease? And the answer is that for 99.9% of the children that are being vaccinated, the answer is no. It's not about trying to protect them from severe disease. Why high-income countries are wanting to vaccinate children is to be able to get sufficient immunity at a community level to interrupt future transmission of the virus. So your so-called herd immunity effect. And that's the only reason why high-income countries are actually vaccinating children, is not to protect children. All that you're protecting them is from being infected or developing mild disease if they do become symptomatic and not severe disease. Now that works in a setting where you already got high penetration of vaccine in the adult population, and in addition to which you've got a vaccine that is highly efficacious in protecting against infectiousness as well as mild disease due to the variant that's dominating in your setting. In South Africa, so in the US, in the UK, the virus that's still dominant in those settings are the Alpha variant, the one that was first identified in the UK, and then the ancestral virus. And that is really what's still dominating in that settings, as well as in Israel, that's an example, where they've shown that by vaccinating just the adult population with the penetration of close on to 70%, you actually get an indirect effect already at that point. And you get a decline in rates of infection in children as well. And that is not by vaccinating children. So we need to ask ourselves why we're vaccinating children. We're not vaccinating them to protect them from severe disease. We're vaccinating them for a public good, in that if we vaccinate a large enough percentage of the population, we could potentially get to herd immunity, which I believe the UK data currently suggests is not necessarily the case in any event. Then there's the issue of safety. So we need to seriously question the risk-benefit ratio of the safety of vaccinating children. And as you correctly point out, although those conditions have been self-limiting, with the Pfizer vaccine, with the messenger RNA vaccine, we are seeing myocarditis. And those cases have generally been self-limiting. Probably wouldn't be picked up in a setting such as South Africa, where we wouldn't have the same sort of threshold for investigating a child that comes in with a tachycardia, as an example. So yes, myocarditis has been temporarily associated with the vaccination, and in Israel, certainly the rate of myocarditis was in the childhood age group was significantly higher than a background rate. There was, I think, one case of a child that actually died of myocarditis, if I'm not mistaken, but it is a more common but usually mild side effect of the messenger RNA vaccines. So for me, I mean, in the South African context right now, we shouldn't even be having a discussion about vaccinating children. We're not going to get more than 70% of our adult population vaccinated. If we do it by middle of next year, that itself would be a major achievement.
Just to finish the story, Shabir, we may get to a stage where we get to that 70%. I accept the argument that children are not a priority. Well, do you see a role for vaccines for children at any stage?
For children that have underlying medical conditions that put them at high risk of developing severe COVID, certainly they should be vaccinated as soon as possible. But for the rest of the childhood population, unfortunately not. And it also depends on which vaccines are available to us. So the Pfizer vaccine, the Pfizer-BioNTech vaccine works surprisingly well, even against the B1351 variant, based on the data that came out from Qatar, in protecting against infection and mild disease, with the 75% effectiveness after the second dose of the vaccine. The Johnson & Johnson, and that is against the beta variant. The Johnson & Johnson vaccine is not going to protect any differently compared with the AstraZeneca vaccine against mild COVID-19 due to the beta variant. So it depends. It's more than just about vaccinating. It's also which vaccines are you using, and what do you expect of those vaccines when it comes to effectiveness against especially mild COVID-19 due to the beta variant, as well as the Delta variant, that would eventually determine whether there's any sort of a benefit in trying to pursue a herd immunity agenda with the current generation of COVID-19 vaccines we've got available to us.
Okay, thanks, Shabir.
Sorry, Aaron. I'm just seeing some of these things here. So there's the high-risk groups, there's a comment that came up, so I'm just going to address it quickly.
Sure.
I'm talking of children that basically have cardiac conditions, chronic lung conditions. I'm not talking of asthma, I'm talking of chronic lung conditions, cardiac conditions. Cancer patients, unfortunately, yes, they should be vaccinated, but there's a big question mark as to whether these vaccines are going to be too efficacious in individuals with underlying malignancies, irrespective of whether they're children or adults. So I think we know which children are more susceptible to developing infectious diseases and severe illness after being infected by viruses. And that would be the category of children that you're looking at.
Thanks, Shabir. So, Heather, I was going to ask you exactly that question about who the high risk are, but do you subscribe with Shabir's view? So what I'm hearing is that they're obviously not a priority now, but Shabir seems to be arguing that even when we get vaccines that are available for children, it's not going to be a high priority vaccine. and I think the argument Shabir is making is that as a cost benefit, there isn't that much of benefit. Are you agreeing with that view, Heather? Do you have a different view?
Yeah, no, I totally agree with that. And I think then there's also an ethical issue. I mean, we are unable to protect the very vulnerable populations with vaccination at the moment who are really at high risk of mortality, hospitalization, and so on. And we've got a long way to go before we get there. So, you know, I actually think there is an ethical issue here. And I think there's an ethical issue in terms of high income countries vaccinating children at this moment in time, when actually vaccines need to shift to low middle income countries, not only for the health of those populations, but also for a global control of this epidemic, because we know that the virus just spreads, you know, with travel and so on. I just want to say one line about high-risk children, which is also a remarkable thing about this pandemic. So we all know, and it's come out now, that children develop less severe disease, undoubtedly, right? They've got like a, I don't know, 13-fold lower risk of being hospitalized than adults, and that includes adolescents in South Africa. And we've seen very little, relatively little hospitalization and relatively little mortality. I think children overall make up about 9% of infections in South Africa and 4% of hospitalizations. And the mortality is really small. And in those group who die, there's majority have, you know, severe underlying conditions. And it's also unclear, because this is from DATCOV data, how many have COVID as a terminal event, how many die with COVID, as you often say, Haroon, rather than from COVID. And I think what is remarkable in this pandemic is how little how children have been spared. And I think the same is true for children with high risk conditions. We don't see this big signal, and this is globally. We don't see a big signal of premature babies or even HIV infected children or children with many chronic conditions actually developing a lot of disease. It's true, severe disease that does develop in that group, but it's really, really a minority of children. And I think this issue of why children develop relatively mild disease and are spared is well, that's saved us in this pandemic. But I think it's a crucial question. It's also a crucial question in terms of understanding immunity.
All right, so I'm going to ask one more question and then go to Mignon to perhaps wrap up any further questions that relate to the whole webinar. So Shabir, I think Heather earlier welcomed the vaccination of teachers. I'm going to be controversial as a last point, that I think we argue that teachers are not a high-risk group, that their risk of getting COVID is the same as the community risk. And therefore, the question is, why are they being prioritized? Do you agree with this decision to go ahead and vaccinate children, to vaccinate teachers?
Yeah, sorry, if you don't mind, I'm just going to answer one of those questions that popped up by two people about multi-inflammatory syndrome in children. The rate of that is so low, and the case fatality risk with that is less than 1%. That in fact, the risk of developing myocarditis will be equal to the risk of a child developing multi-inflammatory syndrome following infection. So we need to avoid sort of getting fixated with really rare type of conditions and using that as a justification to actually use vaccines in children. Should teachers be vaccinated? You correctly stated. In fact, teachers are at a lower risk, or they were at a lower risk until January of 2021 of being infected with the virus compared with people that are working in the service industry. Your person that's working behind the teller that's working in ShopRite probably is more at risk of being infected with the virus, because obviously they've got much more social context than a teacher would have in an average day. So the decision to vaccinate teachers is not really based on science of wanting to reduce severe disease in a specific group of individuals that would have a heightened risk of being infected, such as healthcare workers. It's politically driven. But do I welcome it? I welcome it for the sole reason. Like I said, unfortunately, these teachers are not going to be protected against mild COVID-19. And the danger is that they believe that they've been vaccinated, and then they're going to go to the tea rooms and have lunch and everything else, and then they're really going to be at high risk of being infected. So teachers need to understand that the J&J vaccine is not going to protect them from being infected. It's not going to prevent mild disease. For those that have underlying medical conditions, they should be vaccinated, and it will protect them from severe disease. But there's a danger to it. But the good part of it is that it removes an obstacle from the opening of the schools. So hopefully there's less pushback from the unions as to why schools should remain closed because their members are unprotected. They're going to remain unprotected from mild disease. But yes, for those that have underlying conditions who should have been vaccinated in any case by now, it will provide them confer some level of protection against severe disease.
Okay, thanks, Shabir. So, Mignon, perhaps an opportunity to ask maybe 2 or 3 final questions before we wrap up the webinar.
Arun, can I just add one comment to Shabir?
Yes, go ahead, Heather.
And so I think we mustn't forget that many teachers are high risk. There are many teachers in this country who have obesity, who have immunocompromise, and you know, I think if you look at the statistics that this country has lost over 2,000 educators, educators are a really valuable resource, and we need, you know, I think if there's any way to protect them, and I agree with you, we are protecting them against severe disease and nothing more, but you know, I fully support the vaccination of teachers.
Okay, thank you, Heather.
Can I just ask a question related to that? So a question that's actually popped up as well is, can pregnant and breastfeeding women / teachers vaccinate? So Shabir, that was the last question I had, but because of time, I stopped it. Where are we with pregnant women, and how far are we along that path in South Africa?
Yeah, so for the vaccines that have been evaluated by WHO as an example, the Pfizer vaccine, it is recommended, as well as the AstraZeneca vaccine, is recommended for pregnant women after from the second trimester onwards, not in the first trimester. Breastfeeding is not an issue at all. They should be vaccinated. And the same thing probably applies for the J&J vaccine. But more so if they are at high risk of being infected with the virus, then they should be vaccinated. But the Pfizer vaccine has been shown to be both safe, as well as there's some data that will probably come out soon, which shows that it's also effective in protecting pregnant women from being infected. So can you see it being prioritized in a South African setting, that pregnant women would be higher on the list when we go beyond the over 60s? Well, I think it depends on their age as well. I think it would make more sense to still focus on people above 50 and then those 40 and above with comorbidities. I think pregnant women are still further down the pecking order. Okay, thanks. Mignon, any other things that you want to raise before we wrap up? Among the questions that were asked in the chat line. I think we've done well. I think what we're going to try and do as an enticement to get people onto the website is we've recorded all the questions that have been asked. So we're going to try and answer any of them that haven't been answered on our website. So watch this space. All right, so then it remains for me to thank both our presenters. As always, they didn't fail to deliver. Heather, thank you very much for standing in before Shabir came in, taking in all the hard questions. And then Shabir, your contribution is always valid. So I think what we've learned at the webinar today is that in terms of transmission, there's still a lot of myths about how children are the main spreaders of this disease. And I think we've debunked many of those myths. It's been around for a long time, and we've certainly made the case that children are not the super spreaders in this whole epidemic. In terms of schools, I think the position of SAPA, and I think both our panelists have agreed with the view that we should be continuing to allow children to go to school, both primary and high school, and that measures to prevent the half day, 1 day in, 1 day out are also warranted, certainly at primary school level, and if that's successful, we may even extend it to high schools. And then in terms of the vaccines, I think there was quite a strong view. Children certainly are not a priority right now. And even in the longer term, certainly Shabir, Professor Madhi believes that it's unlikely that we can make a strong case for children having the vaccine. So that's it. So I did see a comment that could SAPA perhaps put up another statement to take these facts that our panelists have presented, and particularly now that we're in the middle of the third wave, and certainly I think the SAPA executive have considered that, and we would certainly hope that in the next week we would summarize some of these recommendations coming from the panelists and from the literature, and actually then make this case, the strong case that children should remain in school. We all recognize the devastating effect, and I think the cost benefit is too high for keep on closing schools. So that's it from my side. So thank you to both panelists. Over to you, Mignon.
Thank you very much. And I must thank Haroon for keeping such a cool head despite technological challenges. A special thank you to Heather and Shabir. If you guys aren't SAPA members yet, I think we need to give you honorary status because you really are our go-to people. So thank you very, very much. But thank you especially to the audience, because without an audience, you can't actually run a webinar. And I must say I'm extremely proud of the fact that we managed to get 500 people discussing this topic. It's been a little bit stressful, so thank you to the whole team for helping out when trying to get people onto the webinar, but thank you specifically to the audience for just your patience. And we look forward to seeing you guys next week when we have another webinar on pediatric feeding and swallowing, what's all the fuss. So in closing, please join SAPA. We are looking at making a better world for children's health in South Africa, all working together. Have a lovely evening, and we'll see you next week. Thank you.
Thank you. And Mignon and Haroon, huge